Hello, my name is Natalie Wong, and I'm a rising junior at Duke University, majoring in public policy, minoring in economics, and pursuing a certificate in innovation and entrepreneurship.
Hi, my name is Fateha Zannath. I'm a rising junior at Johns Hopkins University, and I'm double majoring in public health studies and economics.
This summer, we were mentored by Dr. Herbert Lyerly, who is a professor of surgery at the Duke University School of Medicine. We've spent the past 3 months investigating methods of increasing equity and access to cancer care through 3 different projects, which we will begin to cover shortly. But first, to provide some background. Cancer has been and continues to be a high priority topic on both national and international health agendas. There are over 17 million new cases of cancer around the world each year. However, the burden of cancer is not distributed evenly across different countries, and access to cancer resources and oncology drugs also vary widely across different geographic locations and patient demographics, especially amongst BIPOC populations. The 3 topics that we've studied this summer include increasing racial diversity in clinical trials for cancer drugs, leveraging telemedicine to increase international access to pediatric brain tumor care, and presenting and sharing these findings at the annual Accelerating Anti-Cancer Agent Development and Validation, or Triple Adv Conference. These 3 topics provide a starting point to resolve these issues at hand.
As Natalie mentioned, I will go ahead and talk a little bit about the first project we worked on this summer, which was racial diversity in clinical trials, specifically looking at treatments for cancer. I think it's first important to discuss why addressing racial diversity matters. And the truth is that not only does racial diversity ensure the validity, equality, and scientific rigor of cancer clinical research, it may also reflect who has access to the most promising therapies for serious or life-threatening cancers. To provide some background about our project, on July 9th, 2012, the Food and Drug Administration Safety and Innovation Act was signed by the FDA. This act provides a new designation, breakthrough therapy designation, through Section 902. Essentially, if a drug is designated as breakthrough therapy, FDA will expedite the development and review of each of the prescriptions. And the FDA can either grant or deny the request. Specifically, a breakthrough therapy is a drug that has preliminary clinical evidence that indicates that the drug may demonstrate substantial improvement over existing therapies on one or more clinically significant endpoints, such as substantial treatment effects observed early in clinical development, which is all quoted from the FDA's website. Essentially, breakthrough therapy designation allows us to expedite the process of approving novel cancer treatments. Now, for this project specifically, we reviewed 71 clinical trials that led to the FDA breakthrough therapy designation for oncology drugs between the years of 2017 to 2022. We focused on collecting data about whether these clinical trials reported race and if participating patients represented the racial diversity of the US cancer patient population to further understand essentially our big project of racial diversity in cancer clinical trials. In terms of the actual project, we developed a spreadsheet that compiled clinical trials for cancer drugs with breakthrough therapy designation and focused on stratifying the trials by racial data. If you scan the QR code to the bottom of this poster, you'll be able to see a PDF copy of the master spreadsheet. But some of the components that we included in this spreadsheet included date of FDA approval, date of breakthrough therapy designation, disease indication, prescription name, clinical trial literature that summarized phase 2 and phase 3 clinical trials, and also the racial composition of all of the participants in each of the trials. From the spreadsheet, we found that ultimately, Black and Indigenous communities are the least represented populations relative to US cancer burdens across all of the 71 trials that we took a look at. If you take a look at the pie chart below in the poster, you'll see that 74% of clinical trial participants across all cancers, excluding melanoma, were white. On the other hand, Black clinical trial participants only comprised 10% of the entire population, and only 0.6% of all clinical trial participants were Indigenous. And it's important to note that we excluded melanoma, considering the fact that a majority of patients experiencing and are being diagnosed with melanoma are white, and we didn't want that to skew our numbers. Considering that there's clearly a gap in racial diversity amongst the clinical trials that we've looked at, some of the implications for future research and solutions include developing and creating policies that mandate clinical trial participants to reflect the racial composition of cancer disease burdens in the United States to ensure that we're taking care of the racial equity and justice component in developing and administrating novel cancer treatments. We will be publishing a research paper with an in-depth analysis of the results. And we're also looking to work with faculty at Johns Hopkins University and the University of Texas to cross-check our numbers and include more equity components in the paper writing process. So both of these are kind of our next steps. And the reason why this project is so important is because, as we can see, there is a clear gap in access to novel cancer treatments amongst historically marginalized groups. And what this means is that there are many patients who are historically marginalized and are experiencing various forms of cancer who don't have access to novel treatments just because they aren't represented in these clinical trials. And that is a problem that this project really aims to look at and find ways to mitigate the problem itself.
Next, let's move on to the right side of the poster to the telemedicine as a solution portion of the project. The goal of this project was to investigate how telemedicine can be used to mitigate disparities in pediatric brain cancer care between high income and low to middle income countries. Currently, more than 75% of international cancer deaths occur in low and middle income nations. However, these countries only hold about 5% of the world's resources for cancer care. This results in a survival rate of only 40%, which is half of the survival rate of cancer patients in high income countries. For this portion of the project, I wrote a white paper drawing from scholarly articles that explains the potential applications, benefits, and drawbacks of using telemedicine technologies in brain tumor care. Through this white paper, I found that telemedicine has great potential to innovate cancer care as we know it. Specialists can provide consultation, diagnoses, and care to patients across the world through the use of telemedicine. This has been shown already to decrease mortality rates, decrease the cost of care, while also increasing access to and diversity in clinical trials for cancer drug development. This is a major finding considering what we have already found with the first research topic, that cancer clinical trials are lacking racial diversity. However, I also found that legal and legislative obstacles may prevent widespread adoption of telemedicine. Specifically, regulations regarding cross-border licensing and malpractice laws serve as major barriers to adoption. In terms of next steps for this project, further research should be conducted about potential obstacles to adoption and how they can be circumnavigated. Next, specific telemedicine, telepathology, and teleradiology platforms that are especially useful for brain tumor care should be identified for future use. Lastly, we hope to answer the question of how telemedicine can both progress and prevent health equity. Although the main goal of using telemedicine is increasing access to care, such technology can actually worsen existing disparities if not carried out correctly. This is because vulnerable populations in most need of care are less likely to have access to certain technology infrastructure that may be needed for telemedicine.
For the third component of this presentation, we wanted to take the time to discuss the Accelerating Anti-Cancer Agent Development and Validation Conference, also known as the Triple Adv Conference. The Triple Adv Conference is an annual workshop that collaborates with stakeholders in the healthcare industry to increase access to cancer treatment. This year, the conference will be virtual and occurring in September.
For this conference, Fateha and I collaborated with stakeholders within the FDA, American Cancer Society, American Society of Clinical Oncology, American Association of Cancer Research, as well as many other organizations to develop this conference. We partnered with Blue Sky and Resolve It, which are two logistics companies, to optimize conference registration and technical details. Furthermore, we monitored ticket sales, confirmed conference logistics, and updated registration processes. We also facilitated communication between various actors within the conference to ensure that everything will run smoothly in September.
Ultimately, two of the overarching goals for this project is first, hosting satellite sessions that are separate from the overall Triple Adv conference to create opportunities for further discussion among different stakeholders in providing cancer treatment and making it more accessible. We also hope that the conference content will be used to aid in policymaking decision tools across various countries. We're really grateful for our time as Margolis interns this summer, and we want to thank Dr. Lyerly for giving us the opportunity to work on these three projects that ultimately find ways to make cancer care more equitable and accessible among BIPOC individuals.